Hello, everybody. I would like to welcome you to today's episode of BrainPet Talks. These talks are supported by the company Positrigo, which is a pioneer in nuclear medicine imaging technologies. Today, the focus will be on dynamic amyloid PET. We are very happy to have Professor John McConathy with us from the University of Alabama, Birmingham, in the US. Professor Jonathan McConathy completed his medical scientist training program at Emory University with a PhD in neuroscience. He pursued postgraduate training at the Mallinckrodt Institute of Radiology, MIR, in St. Louis, Missouri, through a residency in diagnostic radiology, followed by a fellowship in nuclear medicine. Dr. McConathy then joined the faculty of MIR in July 2010, where he served as a co-director of the radiology research residency. Dr. McConathy joined the University of Alabama, Birmingham, UAB Department of Radiology in December 2015 and serves as the director of the Division of Molecular Imaging and Therapeutics. In addition to clinical practice in nuclear medicine, he remains actively involved in the development and application of PET tracers for oncology and neuroimaging, as well as the use of simultaneous PET MRI for both clinical indications and research. Dear Professor McConathy, we are looking very much forward to your presentation. Thanks for being with us today.
Well, great. I appreciate the invitation to speak. If you haven't guessed from the title already, I'm going to be talking about imaging biomarkers in Alzheimer's disease and some of the imaging processing techniques we're using in our program. Here are my disclosures, and really the most relevant are Eli Lilly Avid, who makes one of the amyloid as well as the tau tracer I'll discuss, as well as GE, who makes another one of the FDA-approved amyloid PET tracers. So I'd like to start off with an introduction in case you're not completely familiar with the state of molecular imaging in neurodegenerative diseases. And then we'll talk about amyloid and tau imaging, both some of the clinical applications as well as some approaches we're pursuing in our research at UAB. So there are two major hallmarks pathologically of Alzheimer's disease, plaques and tangles. So these neuritic plaques contain amyloid and can be imaged with PET ligands. Similarly, the neurofibrillary tangles in Alzheimer's disease can be imaged with tau PET agents. And we've moved from a time when diagnosis really required autopsy and brain sampling in order to make a definitive diagnosis to being very close to being able to make the diagnosis of Alzheimer's disease ante-mortem. And I think some people would argue that we can do that in patients with typical presentations and imaging biomarkers. There are a number of proteinopathies that occur in neurodegenerative diseases. We'll be really focusing on beta amyloid and tau. There are different forms of tau, and really what we'll be talking about is the form that occurs in Alzheimer's disease. But an important point is that the definition of these diseases are moving more and more towards imaging approaches, certainly for Alzheimer's disease. There's a lot of work on alpha-synuclein and Parkinson's disease as well. And also there are overlap between proteinopathies. So for example, in dementia with Lewy bodies, you can see beta amyloid as well. So some of these markers are not entirely specific for a single neurodegenerative disease in isolation. So why do we want to be able to image biomarkers or have biomarkers for neurodegenerative diseases? One is we'd like to be able to increase the specificity and certainty of diagnosis. This is important for patients and their families, particularly in patients who have mild cognitive impairment or mild dementia, who still can really participate in the plans for the future and their care plans, as well as for both patients and families to have a sense of their prognosis. And this can also be important for selecting the appropriate therapy, particularly with the advent of anti-amyloid therapies. In research, there's been a lot of work understanding the time course and mechanisms of the pathophysiology of Alzheimer's disease. And by having a non-invasive way to follow patients over years, this really has helped us understand the time course and the development of the key Alzheimer's disease pathophysiology in the brain. The advent of amyloid PET really has changed the way clinical trials are done in Alzheimer's disease therapy. Prior to the widespread availability of amyloid biomarkers, roughly 30% of patients enrolled in Alzheimer's disease therapeutic trials didn't actually have Alzheimer's disease, and that presents a major impediment to properly determining if a drug is efficacious. There's also the potential to monitor response to therapy. Again, with the anti-amyloid antibodies, that we can actually visualize the clearance of amyloid from the brain. And while that doesn't necessarily directly correlate with clinical benefit, it is a way to make sure the target is being hit. And I think over time, it will help us understand the timing of pauses or cessations of anti-amyloid therapies. And really where we'd like to get, and we're there, I think, to some extent, now that anti-amyloid therapies are available, we'd really like to be able to identify prospectively individuals that benefit from disease-modifying therapy before they develop irreversible neurodegeneration, or at least stop neurodegeneration at an early phase in the disease. This is important because there's a great number of people with Alzheimer's disease now, and that's only going to grow over the next 30 years or so, primarily as a function of the aging of the population. There's also the concept and the issue that Alzheimer's disease has a very long preclinical phase with gradual decline. And there's a great emphasis on early diagnosis and even diagnosis of Alzheimer's disease pathology before cognitive impairment develops. And this is likely going to impact the efficacy of therapies. And then late phase development of anti-amyloid therapies. I list a number of these. The only one that's FDA approved is lecanemab, but there may be approval of donanemab in the near future. So there's been a number of anti-amyloid therapies in late phase trials, including approved agents. And this is, again, really changing the face of both Alzheimer's disease research as well as clinical care. So we do have a number of agents in our toolbox for molecular imaging. We're really, again, going to focus on the FDA-approved amyloid and tau agents, but FDG is still around and still plays a role in some settings. And dopaminergic imaging is also relevant to cognitive impairment, particularly in patients who might have dementia with Lewy bodies. So we might use ioflupane. If you use that in your practice, you may be familiar with it, Parkinson's disease versus essential tremor, and that's still a potential use of ioflupane. But there's also the potential in people with cognitive impairment to use ioflupane to look for loss of dopaminergic neurons, which could help us distinguish, for example, Alzheimer's disease from dementia with Lewy bodies. So how does the clinical diagnosis of Alzheimer's disease, how does that fare? It's roughly 80% in people who present with probable Alzheimer's disease dementia. My joke is always, at your center, you're probably better. You're probably around 90%. And I say that a little tongue-in-cheek in the sense that dementia experts may perform somewhat better. But this can be really challenging at initial patient encounters. And with patients with complex presentations or comorbidities, where we're not dealing with probable AD, but maybe possible AD, this percentage is relatively lower. And so the other point is that if a patient has other forms of other causes of dementia, this diagnostic accuracy is substantially less. And common forms of, or common causes of neurodegenerative cognitive impairment are dementia with Lewy bodies, and particularly in younger individuals, frontotemporal dementia. Another issue with clinical diagnosis of Alzheimer's disease is that it's advanced typically at the time of clinical diagnosis. And this is probably not adequate for selecting patients for clinical trials and may impact the efficacy of therapy. If a substantial neurodegeneration has occurred, there may be less efficacy from a therapeutic intervention. This is a time course of imaging biomarkers in Alzheimer's disease, where the biomarkers are moving from normal to abnormal as a patient's cognitive status moves from normal cognition to mild cognitive impairment to dementia. And phenotypically, amyloid biomarkers with PET or CSF are the earliest biomarkers that become positive in patients with Alzheimer's disease. And this can precede the detection based on cognition by decades, up to 2 decades. Tau and FDG become abnormal much closer to the conversion from normal cognition to cognitive impairment, and are relatively late compared to amyloid in terms of becoming abnormal. Similarly, regional brain volumes typically atrophy in the hippocampi or other parietal regions, typically become abnormal around the time of conversion. And so it's useful to know this time course, and it's important to realize that amyloid positivity alone is not a great predictor of impending cognitive impairment, although it does increase the risk, whereas tau and FDG abnormalities are much more tightly associated with cognitive impairment and conversion to MCI or dementia. There's a framework that's been developed, and it's actually being reworked, but I still think it's worth thinking about and contextualizing biomarkers in this way. So the ATN framework, amyloid, tau, and neurodegeneration, really refer to some of the key imaging biomarkers, as well as biofluid biomarkers in the diagnosis of Alzheimer's disease, or at least the classification. And so amyloid, as I mentioned, becomes positive earliest. This can be measured in the CSF with PET, and increasingly with plasma, amyloid, and tau measures. And so plasma measures are a very dynamic area of research and may influence how we use amyloid PET in the near future. Tau can also be measured with PET, but also with CSF, and in a less mature way with plasma. And finally, neurodegeneration can be assessed with anatomic MR by looking at things like hippocampal atrophy, FDG looking at patterns of hypometabolism in the brain, as well as looking at total CSF tau. Here are examples of PET-MR performed in 3 different patients, 1, 2, and 3, who have either normal amyloid levels, meaning negative amyloid PET, versus positive amyloid PET in patients 2 and 3. When we start looking at these studies, we want to look at the cerebellum, which is our reference region, both qualitatively and frequently quantitatively in these studies. And you can see that in all 3 of these individuals, there is good gray matter, white matter contrast, meaning there's substantially less activity in the gray matter than the white matter. And this is a reference region. When you look at these clinically and in research, you want to make sure that you assess this contrast. As we move up, we can see that in patient 1, there is good gray-white contrast throughout, similar to the cerebellum. In patient 2, there's loss of or at least reduced gray-white contrast, although we do still see more activity in the white matter than the gray matter. However, it is reduced compared to the cerebellum, so this is still a qualitatively positive study. And then finally, patient 3 really has loss of the gray-white contrast, and so this is a clearly positive study. And you can see this is applicable to multiple slices. And I should mention, there are 3 FDA-approved PET tracers for amyloid PET. They are all similar in terms of their diagnostic performance, but each has slightly different reading criteria. And so you want to make sure that whichever amyloid PET tracer, you're following the recommended reading criteria for that particular tracer. In terms of how we might use amyloid PET clinically, and the implications of the results. This is a biomarker for pathologic amyloid deposition, and it precedes clinical findings by up to 2 decades. And it's important to realize that evidence of Alzheimer's disease pathophysiology based on a positive amyloid PET scan does not equate to dementia, i.e. cognitive impairment. And when you have a negative amyloid PET scan, that means there's not sufficient amyloid in the cerebral cortex to make the diagnosis of Alzheimer's disease pathologically. So a negative scan is fairly easy to interpret in the sense that the cause of the patient's cognitive impairment is almost certainly not Alzheimer's disease. In contrast, a positive amyloid PET scan does not definitively establish the diagnosis of Alzheimer's disease or another neurological disorder, because there is overlap between amyloid and dementia with Lewy bodies. And similarly, particularly in older people over the age of 65, and particularly as you get closer to the age of 80, the frequency of a positive amyloid PET increases substantially. That doesn't mean a positive amyloid PET doesn't support the diagnosis of Alzheimer's disease in the correct clinical setting. That may be sufficient to make that diagnosis and treat with anti-amyloid agents. But just keep in mind, there is a little more ambiguity around an amyloid PET scan that is positive, and there's more information needed. There's a study that's been done, that the IDEA study, looking at coverage with evidence development for clinical amyloid PET. This was in Medicare beneficiaries. It was a nationwide study with over 10,000 patients enrolled, looking at impact of patient scan on patient management at 3 months and major medical outcomes at 12 months. Slightly over half of patients with MCI had a positive amyloid PET, and about 70% of those with dementia were also positive on amyloid PET. And that's roughly the frequency of Alzheimer's disease in the US population in older individuals. That changed the diagnosis in 25% of patients from AD to non-AD, and changed the diagnosis from non-AD to AD in 10% of patients, and changed treatment planning in 60% of patients, most often medications followed by counseling. So even in the absence of anti-amyloid therapies, amyloid PET can impact both the diagnosis and the care of patients. As we enter the era of anti-amyloid therapies, another potential application is selecting people who might benefit from anti-amyloid therapy. These therapies are antibodies that directly target amyloid, and thus showing that a person has amyloid in the brain is a prerequisite to enrolling them, or I shouldn't say enrolling, for starting them on anti-amyloid therapies. Now, that may be achievable with CSF or with plasma biomarkers as well, but amyloid PET is one way to qualify patients, and that's our primary method currently at UAB clinically. What's interesting in addition is that if you follow amyloid clearance these are 3 different anti-amyloid antibodies, donanemab, lecanemab, and aducanumab, you can see that in the placebo group, there's essentially very little change in the amyloid burden in the cortex, whereas there's substantial clearance over the course of about a year in patients receiving these drugs. And in the aducanumab, these different bars are different doses in different brain regions. And so with all of these agents, we can see substantial clearance of amyloid from the brain. Again, this doesn't necessarily correspond directly to clinical benefit in terms of slowed cognitive decline, but this is another application of amyloid in routine clinical use. So an area we have been interested in is how we can use simultaneous PET-MR in the evaluation of both our research and in the near future clinical patients to improve their care. One of the simple advantages of simultaneous PET-MR, but it shouldn't be underestimated, is that we truly are acquiring the MR and the PET at the same time. So when we acquire PET-CT, even though we think of it as one study, they really are sequential. The CT and the PET are not acquired at the same time, but simultaneous PET-MR, the MR is being acquired while the PET's being acquired. And so the nice thing about this is if a patient needs a brain MRI, for example, to look for microbleeds or white matter disease in preparation for anti-amyloid therapy to evaluate them for amyloid-related imaging abnormalities or ARIA, they can have that MR done along with their PET rather than have a PET and an MR at a separate time. But this also allows us to acquire dynamic PET. And as I'll show you later in this presentation, there's the potential to use that amyloid PET dynamic phase to get additional information that we don't get just from the typical delayed static imaging with amyloid PET that gives us our amyloid level readout. So we have found with our clinicians that there's a real preference for using quantitative methods in our studies. And one of the advantages is we can use volumetric MRI to use segmentation, in this case with FreeSurfer, but we can also use this clinically with FDA cleared segmentation techniques. And really this method is agnostic to the method of segmentation. So if you have a favorite one, you could implement this. And so with the MR-based segmentation, we can then fuse this within our clinical viewer to define various brain regions. And the exact brain regions and the size of the parcellation regions is going to depend on your method of segmentation. In our clinical viewer, we can then review the areas of, or the regions defined, edit them if necessary, or at least be aware of errors, and then apply this to PET in order to get time activity curves for a dynamic study, or to get measures of SUVR or cynoloids if we're just interested in a static image. And so we published this about 5 years ago. This compares well to quantitation done in ADNI, and we do this routinely as part of our ADRC, Alzheimer's Disease Research Center quantitation, and we are starting to do this clinically, particularly in patients being evaluated for anti-amyloid therapy, or those who have actually completed or having anti-amyloid therapy to look for clearance. And these are just measures showing that our global measurements of amyloid burden with our Blazer method correlate well with patients, or I should say research subjects from ADNI. And generally our results were within a few percentages of the reference standard. We also compared, so this was with FreeSurfer, we also compared a commercially available algorithm where we're able to send the volumetric MR, return it back to us within roughly 10 minutes, and then use that for both volumetric brain assessment as well as PET quantitation. And again, we got very similar results, although there was more difference from the reference standard with a little bit of positive or increased SUVR bias in using this commercially available segmentation, which is, we think, predominantly because the cortical thickness defined by NeuroReader compared to FreeSurfer was slightly thicker. And we found, though, that if we, even if we didn't adjust the cutoff, we had very few discrepancies. And if we adjusted the cutoff, we could have virtually very, very few discrepancies between the ADNI reference set and our results. And some of this is really with individuals who have SUVR cutoffs truly right around the cutoff, so differing by 0.02, 0.03. Very good inter-operator reliability. So we had an MD PhD student and an undergraduate run this, and they were able to get very similar results to each other with both amyloid and tau. I don't know if this will show well, but let me kind of just show this in action. And basically, we have implemented this in MIM Encore, which is a commercially available viewing and imaging platform. I think it could be implemented in other systems, but the key is you need to be able to automatically generate the regions of interest. And so here we've already done our segmentation. Now we're going to load that with the volumetric MR. This table shows us the options, and this workflow will automatically define these brain regions based on the MR segmentation, show them on the native MR for quality control, and then automatically have them fused with the PET for quantification. Now, this is not a new concept or one that we developed. People have been using MR-based segmentation for PET quantification for a long time. But I think a key advantage for this approach is it's easy to visualize. It's in our software that we use every day for reading PET and other nuclear medicine studies. There's the potential to edit and customize workflows. And so while I think there are a number of viable solutions, I do think this bringing quantitation into people's usual environments is a better approach than asking imagers or technologists to learn 20 different pieces of software for each quantitative technique that's needed. Here's an example of using this approach in a real patient. So this was a 64-year-old woman who had hypertension, hyperlipidemia, carotid stenosis, who has mild stage dementia of unclear etiology. And interestingly, the patient really presented with language symptoms predominantly during the first 2 years, particularly difficulty finding words. Her outside brain MRI did show some cerebral white matter T2 flare hyperintensity. So, the possibility of microvascular disease contributing to her cognitive impairment was definitely a possibility. And on neuropsychological evaluation, she did have prominent language deficits, but also visuospatial executive memory and fine motor skill deficits. So this patient, potentially could have Alzheimer's disease or another neurodegenerative disease, but vascular risk factors could play a role. And from the memory specialist point of view, the major differential really was logopenic aphasia as a variant of Alzheimer's disease versus a somatic variant of frontotemporal dementia. And what's really important is if this is Alzheimer's disease, this patient might be eligible for anti-amyloid therapy, whereas they would not if they had frontotemporal dementia. So here you can see their amyloid PET is clearly positive. There's really loss of gray-white contrast throughout the brain, and there's even some cortical regions that look like they have higher activity, for example, here in the left occipital cortex compared to white matter. Using the volumetric analysis from the MR segmentation, we can see that her temporal lobes, particularly her left temporal lobe, is well below the 25th percentile, which is what this system uses for flagging abnormality. But compared to other brain regions, those are much more similar to the mean. And so this is evidence of neurodegeneration in a location that fits her language predominant initial presentation. And then we can use that segmentation that we use for MR volumes to then apply to our brain regions. And in this case, we're expressing the data as SUV ratios. We're in the process of bringing on board Centiloids for our clinical reports. But regardless, there's clearly elevation above our cut point in these brain regions, confirming the qualitative assessment. And these kind of measurements would be critical if we were to follow this patient in terms of clearance of amyloid over time. And similarly, in the MR part of this exam provides us with assessment for white matter hyperintensities, as well as evidence of microhemorrhages, which is really important for following patients as they are treated with anti-amyloid therapies, because they may develop edema or hemorrhage, which may require them to reduce the dose, suspend, or even stop therapy, depending on the symptomatology as well as the imaging severity. So, overall, the combination of amyloid PET and MR in this case allowed us to show that the patient was amyloid positive and had evidence of neurodegeneration in the left temporal lobe. And so, this patient almost certainly has logopenic aphasia due to Alzheimer's disease. Switching gears a little bit to tau. Tau is less uniform and starts in the intrarhinal region and then slowly spreads through the brain. And this has been staged with Brock staging 1 through 6. And in healthy older individuals, some tau deposition in the medial temporal lobe may be within normal limits. But as this spreads into limbic regions and then into neocortical regions, this is clearly pathologic, and the amount of spread correlates with the severity of cognitive impairment in Alzheimer's disease. So the only agent that's currently available is fluorotaucipir. There are a number of other tau PET tracers in late phase development. And as I said earlier, most of the agents, although there are others in earlier development, but most of the agents really work well for the form of tau that occurs in Alzheimer's disease, but may not work in other tauopathies that are not related to Alzheimer's disease. And the main point is that the sensitivity and specificity of this agent is good in patients with fairly widely distributed tau pathologically, so in neocortical regions. It can miss more limited pathological tau in Alzheimer's disease. But if you see a positive scan, this is good evidence that there is tau in neocortical regions. These are typical images in a negative study. The way this is read is a bit different than the amyloid agents. Here, a two-dimensional ROI is defined in the cerebellum, and then this is used to apply a threshold to the PET images. So up top is just grayscale. Below is a scale where everything that is 1.65-fold or below the mean counts in the cerebellum, the reference region, are shown in grayscale. But areas that exceed this 1.65-fold threshold are shown in color. And as the SUVR increases, you can see that the color scale changes. Here, this is a negative scan because fluorotaucipir does have some off-target binding that can occur in the basal ganglia as well as the choroid plexus. So these are not considered abnormal. Here's a clearly abnormal fluorotaucipir scan. And really the criteria are activity extending outside of the medial and anterolateral temporal lobe, in the parietal cortex or occipital cortex. And here we can see that quite clearly. There may be a little bit of frontal. These small ditzels, though, in isolation, you may not want to include, but these areas are clearly positive. So as I mentioned earlier, tau is a marker for pathologic tau deposition with a much stronger temporal correlation to neuronal injury and cognitive impairment than amyloid. And fluorotaucipir and many of the other tau ligands bind to the form of tau that occurs in AD, but not other forms of tau. So if you're dealing with a patient who may have a tau proteinopathy causing frontotemporal dementia, that doesn't mean that you can use fluorotaucipir and many of the other tau ligands to detect that form of tau. And again, while there's a much closer tie between tau and dementia, in isolation, we need to be careful about assuming that a positive tau scan by definition means a patient has dementia, although the risk is much higher than from a positive amyloid scan alone. And so a positive tau PET scan really does help support the diagnosis of Alzheimer's disease in the setting of cognitive impairment. But a negative scan, while it may mean that the tau is not widespread, we may be missing tau pathology that could give the diagnosis of Alzheimer's disease pathologically. So we need to have there's some room, I think, for improvement in terms of the sensitivity for earlier stages of tau in Alzheimer's disease. So this slide is a nice summary explaining why it's important to know both amyloid and tau status in terms of prognosis. So these are cognitively unimpaired older individuals who have amyloid and tau status known. And here we're looking at progression to mild cognitive impairment. Here we're looking at progression to all-cause dementia over the course of 6 years. Those who are amyloid negative and tau negative in red had the least progression. But importantly, those who are amyloid positive but tau negative here in this cyan had only a little more progression to mild cognitive impairment and very little progression to all-cause dementia. In contrast, those who are amyloid positive and tau positive, either in the medial temporal lobe or the neocortex, had much more progression to mild cognitive impairment. And in terms of progression to dementia, really it was only those who had both amyloid positivity and neocortical tau who had substantial progression to all-cause dementia in the time course. So knowing amyloid status alone does have some prognostic value, but really you need to know the tau status in terms of prognosis for cognitive impairment over a relatively short period of time. I'd like to illustrate another case. This is an 87-year-old man with subtle memory changes that began about 10 years prior to presentation. His mini mental status exam was 30 out of 30. He was receiving an acetylcholinesterase inhibitor. And you can see really his mini mental status exam has been stable over time. Interestingly, he is at this time amyloid positive. So you can see that compared to the cerebellum, he has loss or at least reduced gray-white contrast really throughout the cerebral cortex. But importantly, he is tau negative. And so while this man is at higher risk for developing Alzheimer's disease than if he were, and by that I mean cognitive impairment due to Alzheimer's disease, than if he was amyloid negative, the fact that he is tau negative means his risk of progression is very different and much less than someone who is amyloid positive and tau positive. And this may become increasingly important in terms of selecting patients for anti-amyloid therapies and other Alzheimer's disease therapies that are developed. So, and just to summarize this case, amyloid positive, tau negative, volumetrically normal by MRI with stable, very subtle cognitive impairment. So again, at his age of 87, he may have some other cause of mortality before he ever develops cognitive impairment due to Alzheimer's disease. So to kind of talk about another aspect of research and coming back to how we can utilize particularly PET neuroimaging more efficiently, interested in how dynamic amyloid PET could help allow us have a comprehensive neuroimaging evaluation. We like to perform this in conjunction with simultaneous PET-MR. However, there is no reason that you could not do this with dynamic amyloid PET with a separately acquired MRI as well. And in fact, many patients may undergo diagnostic MRI before they present to us for PET. And in those cases, there may be no need to repeat an MR. And so this is a tau scan that is clearly positive. And I'm going to show you as well one image, which is an FDG PET, and another image, which is the very first frames, the flow phases from an amyloid PET scan. I'll let you test yourself and guess which is which. So this is the flow from an amyloid PET study, and this is FDG PET. And you can see a couple of salient features. First, the areas of decreased flow, relatively speaking, on the amyloid scan are very similar to the areas of decreased FDG metabolism throughout the brain. And I think in this case, it would be very easy to convince someone this is an FDG PET scan in a patient with Alzheimer's disease. We see decreased posterior cingulate and precuneus activity and this typical posterior parieto-temporal distribution of decreased flow and decreased metabolism. And in most situations, FDG and flow are tightly coupled. So this is not surprising. The other interesting feature is you can see that the areas of tau positivity are kind of mirror images of the areas of decreased flow and metabolism. So this got us to thinking, could we use the flow phase from a dynamic amyloid PET scan to get FDG-like information and potentially get information that might predict tau status? And so, using PET and MR together, either separately acquired or simultaneously acquired, we might be able to get the 3 ATN biomarkers in a single, roughly 60-minute imaging session. So this is work that was led by Fabio Ramon, who's a MD PhD student working with Eric Roberson and myself, as well as other colleagues at UAB, Chad Murchison and Dean Fang. and collaborators at Washington University in St. Louis, particularly Tammy Benzinger. And we used data from the WashU ADRC in order to get this study done. And the main point here is if we look at the flow, the dynamic flow, if we look at the dynamic uptake of amyloid PET tracers, at early time points, blood flow dominates. And then at later time points, there's clearance from the brain regions that, all brain regions with greater clearance from those with less amyloid PET. So we can use this early frame amyloid PET to get flow-like information, and later on in the study get amyloid binding information, again, within about 60 minutes of total scanning. So in this study, we basically, it's a retrospective study. We looked for patients who had both dynamic amyloid and static tau studies, and we ended up with a final data set of 57 amyloid negative, 63 amyloid positive. And we did have, some technical reasons patients might not, or participants might not be included in our study. And what we did was look at which brain regions were most predictive based on dynamic amyloid PET of tau positivity. And we looked also at cerebral white matter and whole cerebellum as reference regions. And we found actually that the hippocampi were the best regions overall for predicting tau. And this was using both a composite as well as individual tau regions. And we found that white matter performed better. These numbers are area under the curve measures. And so the higher the number, the better prediction. Here are two extreme cases. This is a healthy individual who's amyloid and tau negative. You can see there's good flow and normal volumes in the hippocampi. In contrast, this patient with Alzheimer's dementia has marked hippocampal atrophy as well as reduced flow in the medial temporal lobes, including the hippocampus. And you can see they're tau positive in neocortical and temporal regions. And these are extremes. And one of the questions we had was whether the atrophy in the hippocampi was why we were getting a lower SUVR, that we were getting partial volume. And so we looked at that. If we looked at our prediction of tau using a quantitative cutoff, we can see that in those who are amyloid positive, the blue circles, really that if at a cutoff around 1.1, we had good distinction between those who are tau positive and those who are tau negative. Not perfect, but good prediction. Whereas, as you would expect in the amyloid negative, there really wasn't a correlation. And you can see that our using the early frame amyloid PET from the dynamic scans, we outperformed hippocampal volume alone for predicting tau. So early days, but I think this is an interesting approach that might provide more information from amyloid PET than we get from a simple static measure. The challenge is that is more time on the scanner, and so it needs to fit in with a clinical workflow. We also have been looking, and this is not yet published, but we have a manuscript in submission looking at this, is the relationship between early frame amyloid PET and cognition. And we selected individuals who had at least 18 months of cognitive follow-up. And we looked at both our simple ratio of the reference region and the hippocampi, as well as a more formalized measure of delivery of tracer R1 from kinetic modeling, which is a more mathematical, a little more complicated to implement, but a more formal way of representing tracer delivery or flow type measures. And really the punchline is we found that there was both hippocampal simple ratios with early frame amyloid PET, as well as the more complicated R1 predicted tau, and actually performed very similarly in terms of area under the curve. And we also found that these could predict some of the progression to cognitive impairment over time based on these measures. R1 was a little more robust than early frame amyloid PET ratios, although both worked. And we think that the R1 may be a better calculation because it's less susceptible to variability in the PET tracer injection. So with that, I'm going to stop. I hope I've given you an overview of imaging biomarkers and how incorporating amyloid PET with dynamic components may have some predictive value for tau as well as cognitive status. Again, not proposing that this replaces tau PET, but I think if we can get more information from a single study, there may be some value. And again, bringing in MR-based techniques for both segmentation and volumetry may also add to the diagnosis. So again, I appreciate your attention. I hope you found this talk interesting and useful, and feel free to contact me if you have any questions. Thank you.
John, thank you so much. We have some time for just a few questions here.
Sure.
I think there's huge value, as you mentioned, on dynamic amyloid PET. However, it's probably right now currently used in research.
Yes.
Do you think this could eventually move into clinical routine?
Maybe.
Potential time frame, or what are the main disadvantages that we don't see it yet?
So I think two main disadvantages. One, we need more evidence that this really is predictive. This is a retrospective study. We are interested in looking at our cohort and potentially collaborating with others to have a larger cohort to determine, does this really work? How scanner and protocol dependent is it? I think R1, which is more complicated, but it's not that hard to implement, may give a better, more robust measure. The other, so one is just proving that it works. Then I think the other piece is the extra scanner time. And so that is potentially a major challenge for PET CT or PET only systems. And that's one of the potential advantages of PET MR, but that's only if the patient also needs a diagnostic MR as part of their evaluation, which is not always the case.
Right.
So I think that one of the questions is, even if it does work, how valuable is that information? Is it worth an extra slot that you're taking up on the PET scanner?
Yeah, that makes sense. Now, we talked a lot about, obviously, imaging. When it comes to Alzheimer's disease diagnostic, there's a lot about blood biomarkers right now. How do you see this developing going forward? Do you think blood can replace PET eventually, or is this more used in combination? What's your take on that?
So, best way to be wrong is predict the future. But I do think that plasma biomarkers, especially for amyloid status, will obviate the need for some amyloid PET. I think one of the questions will be, can we eliminate people who are clearly negative or clearly positive, and then a subset need to go on and have amyloid PET and I'm thinking really of qualifying for anti-amyloid therapy. I think that's one likely scenario. An unanswered question is, if we decide clinically that there's value in measuring amyloid clearance to make further treatment decisions, it's unclear that the plasma biomarkers will be as effective as amyloid PET. It could be that they are. And I do think, one of the issues is cost of amyloid PET, although the plasma biomarkers are not cheap either. But really, the availability of amyloid PET, here in Alabama, there are many people who are hours away from a place that's going to offer amyloid PET. So if they could have a simple blood test in the office, there are lots of advantages to that. I think tau is trickier in the sense that the spatial distribution matters, and it may be harder to replace tau with plasma biomarkers alone. And those are less mature. But I do think it's an area that we need to keep an eye on. And, you could view it as a competing technology. In the end, I think if it's effective, it's going to give more people access to biomarkers. And I think there will still be roles for PET imaging. They may be less wide open in the future than they are now.
Thank you very much for these answers. Well, we come now to the end of today's episode of BrainPad Talks. I would like to thank Professor McConathy very much for his insightful presentation. It was very interesting. I would like to thank you all for your participation, and I look forward to seeing you again during one of our next episode of BrainPad Talks. Thank you so much. Bye-bye.